Hello again, I'm Paul Della here for our last and final talk for the day. I'll give you an update on scleroderma, Sjogren syndrome, and myositis. These are my disclosures. And our outline will start briefly with clinical manifestations, diagnosis, and treatment options in these respective diagnoses. Systemic sclerosis, otherwise known as scleroderma, as you know, is a complex systemic disease that can affect many organs, including the skin, lung, heart, GI tract, and kidney. The pathophysiology involves vascular and endothelial dysfunction, autoimmunity, and fibroblastic activation and proliferation. Scleroderma means hardening of the skin, and it can be localized, such as what's called morphia, like this, so-called cul-de-sac, or it can be what's called systemic sclerosis, which can either be diffuse or limited disease. And then there are other autoimmune diseases that can have a component of scleroderma-like findings. Limited systemic sclerosis is what you see when skin thickening is typically below the arms, past the elbows, or below the knees. Crest is one feature of this, where people can have a variety of findings such as calcinosis, telangiectasias, sclerodactyly, which is thickening of the fingers. They can also have esophageal dysmotility and Raynaud's. Remember, the difference between limited and diffuse scleroderma is that the skin thickening is typically in limited disease in the face and the forearms and the lower legs, and in diffuse, it's in the face and trunk, and the entire arms and the entire legs. It's important to recognize that diffuse disease is more highly associated with lung disease, and limited disease is more associated with pulmonary hypertension. However, there is overlap between these two very important findings. And as you can see, the survival between the two, whether it's limited or diffuse, is different. So patients who have limited scleroderma have a higher 10-year survival rate than those who have diffuse scleroderma. So understanding the presence of skin disease and the distribution of that skin disease can predict not only the organs that are involved, but also the prognosis. And this just reiterates that. These are what are called puffy hands. And if a patient ever comes in and complains, my hands are puffy or my fingers are puffy, scleroderma is a diagnosis that you need to consider. The differential diagnosis of puffy hands or puffy fingers is scleroderma, dermatomyositis, and other autoimmune diseases that are similar. But these diagnoses are very important. Puffy hands are a very important clinical feature in early scleroderma. There's edema and inflammation at this stage before the skin becomes matted and sclerotic. As time goes on, the edema or inflammatory phase is less prominent. The skin gets very shiny, and flexion contractures can develop. This is a so-called mouse face or tightness around the lips. It's a so-called perioral changes where a patient can actually have difficulty opening their mouth. Patients who have early scleroderma will often describe that their mouth doesn't open as it used to. And the natural history of skin tightening is very interesting in that diffuse cutaneous involvement develops early, and then the skin will sometimes loosen after 3 or 4 or 5 years. But remember, many of the complications associated with diffuse scleroderma, such as lung disease and heart disease and kidney disease, occur early in the first few years, whereas in those patients who have limited cutaneous involvement often develop complications later, such as pulmonary hypertension, which can occur 5, 10, and even 15 years later. So that's something to keep in mind. Raynaud's phenomena. This is important. It's a not infrequent initial presentation of connective tissue diseases. It involves an episodic reversible digital skin color change where the fingers or digits of the toes sometimes can go from white to blue to red. It's well demarcated. It's due to vasospasm. It's usually related to cold, but other factors can provoke it, and it's reversible. This is a great example of Raynaud's phenomena. If a patient ever tells you they have Raynaud's phenomena and you don't see it at the time you're examining them, ask them if they have a picture on their cell phone, because when it looks like this, you can feel confident that this type of ischemic, distal, well-demarcated ischemic phenomena is consistent with Raynaud's, and that rewarming can relieve this problem. As you can see, in a different phase, the fingers can become cyanotic looking and often red, and then return to normal with rewarming. Remember, there's a difference between primary and secondary Raynaud's. Primary is typically in young women, younger age, below 30, often with a family history, and most are ANA negative. Secondary Raynaud's, however, typically occurs after the age of 35. They may develop digital ulcers, they may have abnormal capillary microscopy, and they typically have positive antibodies. If you see someone with Raynaud's after the age of 35, you need to be suspicious for the development of some type of autoimmune disease. So in secondary Raynaud's, any connective tissue disease, including lupus, mixed connective tissue disease, Sjogren's, dermatomyositis, Scleroderma, those are the important connective tissue diseases that can be associated with secondary Raynaud's. And then there are a variety of other diseases, including occlusive arterial diseases, including antiphospholipid antibody syndrome, vascular injury due to trauma or drugs, and cold reacting proteins or hyperviscosity syndromes. Here's a digital ulcer that can occur in severe Raynaud's, associated in this case with Scleroderma. And these are the nail fold capillary microscopic changes that you can see if you use an ophthalmoscope or other microscope that allows you to visualize these blood vessels. These ectatic blood vessels are abnormal, and they are not seen in normal patients, which this is a representative of. In Scleroderma, most patients are ANA positive, but not always. They may be nucleolar positive when they are ANA positive. The centromere antibody is positive in 2/3 of patients with limited Scleroderma, and the anti-SCL70 antibody is positive in about 30% of patients with diffuse Scleroderma. There are other antibodies that you should know about, including the RNA polymerase III, which puts Scleroderma patients at an increased risk for renal crisis. And there are some other antibodies here as well. Internal organ involvement is important. Interstitial lung disease is by far the most leading cause of mortality, and occurs up to 75% of patients with diffuse Scleroderma, and often occurs within the first 4 years of disease onset. Pulmonary hypertension, more common in limited Scleroderma, and occurs later in the course. Some patients can get both, which prognostically is bad, and there are an increased risk of malignant lung neoplasms in patients who have Scleroderma. Renal crisis occurs less frequently than before because of our recognition of this problem, but it does occur typically in early diffuse disease. It's treatable with ACE inhibitors, and the use of ACE inhibitors has cut the mortality of this and morbidity and mortality associated with renal crisis and Scleroderma significantly. But it's important to watch for, and prompt treatment with ACE inhibitors is extremely important. Cardiac involvement can occur in a number of patients, which can include congestive heart failure, myocarditis, and pericarditis. And GI involvement is extremely common, with GI involvement involving the esophagus, gastroparesis, and vascular ectasia in the antrum of the stomach. This is interstitial lung disease, showing this reticular and ground glass appearance in the parenchyma. And this is esophageal dysmotility, which is common in patients with Scleroderma. Treatment in the modern era involves the use of a variety of drugs, including MMF or cyclophosphamide. MMF is a mycophenolate, which is now the preferred agent typically for patients with interstitial lung disease and skin involvement. There has been studies that have shown modest improvement with in terms of lung function and skin scores with both of these drugs, but since mycophenolate is less toxic, we use that preferentially. There are drugs that are now approved as antifibrotics, which can now be used in Scleroderma. Nintedanib is one of them. It was recently approved for Scleroderma lung disease. It does not affect the skin, but it can be effective in slowing fibrosis and lung function decline in patients with Scleroderma ILD. There are multiple trials in process with regard to treatment of interstitial lung disease in scleroderma. So there has been progress. In renal disease, there are ACE inhibitors. In pulmonary arterial hypertension, there are a variety of agents. In reflux, there's PPIs and anti-reflux surgery. And in Raynaud's, there are a variety of agents, including endothelin antagonists, prostacyclin, phosphodiesterase inhibitors, surgery, and Botox. And then finally, lung transplant, and even allogeneic stem cell transplant and bone marrow transplant in some patients with scleroderma can be utilized in patients with severe and rapidly progressive disease. This is just another recent addition, myeloablative autologous stem cell transplantation for severe scleroderma. Again, in select centers, it can be utilized and appears to be superior compared to cyclophosphamide. So the key points in scleroderma: ILD, or interstitial lung disease, remains the leading cause of mortality. Treatment options have improved. Remember that Raynaud's that develops greater than or over the age of 35 raises the concern for some type of rheumatic disease. Remember, the presence of concomitant Raynaud's and GERD should always raise the suspicion for someone with some type of scleroderma. Pulmonary hypertension is a complication of longstanding limited scleroderma. Screening is essential, as treatments are available that improve morbidity and possibly mortality in these patients. Let's move on to Sjogren syndrome. This is an autoimmune disorder characterized by salivary and lacrimal gland dysfunction. Patients become dry in their mouth and their eyes, so they have decreased production of tears and saliva. There are primary and secondary forms of this. And the point is that some patients have primary disease where basically all they have is Sjogren syndrome, but there are many patients who have RA or lupus or other autoimmune disorders who have secondary Sjogren's. The Zika syndrome is characterized by ocular dryness, corneal injury, oral dryness, dysphagia. They have increased risk for dental caries and thrush. They can get nasal dryness and then vaginal dryness as well. These are the classification criteria for primary Sjogren's. Rho antibody is positive in about 60% of these patients. So there are some criteria that can help you identify patients who are at high risk for Sjogren's. The problem with antibody testing for Sjogren's is that not everyone has a positive antibody. So if the Rho antibody is negative, you need to remember that they can still have Sjogren's because it's only positive in about 2/3 of the patients with disease. This is a person with large parotid glands in the context of someone with Sjogren's syndrome. This is a person with dry eyes and corneal abrasions associated with Sjogren's syndrome. And this is a person with very dry mouth associated with Sjogren's syndrome. However, Sjogren's syndrome is more than just dry mouth and dry eyes. These patients can get a peripheral neuropathy. They can get a vasculitis. They can get interstitial lung disease, which can be severe. They can get joint involvement, and they can have an increased risk for lymphoma. Risk factors for more aggressive Sjogren's syndrome include the presence of a concomitant positive rheumatoid factor, low complement, and the presence of cryoglobulinemia. Here's a patient who's 50 years old, known Sjogren's syndrome, Rho antibody positive, who developed an 8-pound weight loss and then had these multiple nodules in the lung. She had a lung biopsy done, which showed a marginal zone lymphoma. These patients may need treatment for these lymphomas and may respond to typical treatment for lymphoma, but a degree of suspicion has to be considered. If you see a patient with Sjogren's who's losing weight or has fevers, you need to be concerned for the possibility that they are developing secondarily a lymphoma. Sjogren's can also be, as I mentioned, associated with other conditions: lupus, rheumatoid arthritis, and systemic sclerosis. Some patients can have, there is an association with hypothyroidism, autoimmune hepatitis, and cryoglobulinemia. So if you have a patient with Sjogren's syndrome and you notice their alkaline phosphatase going up or their LFTs increasing, you need to consider whether they have autoimmune liver disease or biliary disease, which can be associated conditions. Treatment for Sjogren's syndrome is largely treatment-based, so xerostomia is treated with oral hygiene. and agents to stimulate salivary secretion, which can help. These are muscarinic agonists. Treatment for extraglandular disease is difficult, but there are multiple ongoing trials. Drugs like hydroxychloroquine may be useful in those patients who have arthralgias, joint pain, and fatigue associated with Sjogren syndrome. So the key points about Sjogren's: this is a higher risk of non-Hodgkin's lymphoma, about 5% lifetime risk over the normal. Most cases are secondary to other rheumatic diseases. Treatments are geared toward managing Zika syndrome and optimizing and promoting oral and ocular hygiene. Treatment of extraglandular disease is challenging. Remember, patients with a low positive ANA, fatigue, and eye and mouth dryness are a significant challenge diagnostically. We don't always know what these patients actually have. Sometimes they'll be empirically treated. Let's move on to inflammatory myopathies. These are a group of disorders where they have immune-mediated muscle injury. Usually these patients have muscle weakness and elevated muscle enzymes, including CK and aldolase. Sometimes the liver enzymes may also indicate that they have an elevated CK and aldolase, so that's something to watch for. These disorders include dermatomyositis, polymyositis, overlap myositis with other systemic rheumatic diseases. Then there's inclusion body myositis and what's called necrotizing autoimmune myositis. These can often be associated, they sometimes be associated with statins as well, so that's something to keep in mind. And here's a broader list of some of the disorders that can be associated with inflammatory myopathies, including infections and electrolyte disturbances, and of course, always keep in mind hypothyroidism. Remember, inclusion myositis is different than the typical inflammatory myositis. Inclusion myositis, body myositis, typically involves males. It's usually in an older population. There's a slower progression. Typically, there's more distal involvement. The typical inflammatory myositis is more proximal in nature, and the prognosis in terms of treatment with a response to anti-inflammatory immunosuppressive therapy for inclusion body myositis is poor compared to typical inflammatory myositis. So if you have a patient who is being treated, quote unquote, for polymyositis or dermatomyositis, and they're not responding to therapy, you need to begin to wonder whether they may have something different, such as inclusion body myositis. And that's important to consider. This is an example of someone with inclusion body myositis. This person has inflammatory myositis with this very profound amount of inflammatory cells within or around muscle fibers. But in this patient here with inclusion body myositis, you notice that there's a paucity of inflammation and these vacuoles here, which are characteristic of this disorder. Remember, in dermatomyositis and polymyositis, the key features are proximal muscle weakness, which occurs in the majority of patients. Patients with dermatomyositis typically have skin involvement. Then there's a condition called amyopathic dermatomyositis, where the patients have skin involvement, which is classic for dermatomyositis, but may have either minimal or absent muscle weakness or evidence of muscle inflammation. Here are the classic Gottram papules associated with dermatomyositis, scaling over the external surfaces of the hands, heliotropic rash, which can be seen, erythema around the eyelids, a shawl sign here, which is typically photosensitive, erythema around the nail beds, or a so-called periungual erythema, another hallmark of dermatomyositis. And so that's important to keep in mind. The other key point to keep in mind is that with these disorders, patients have a higher risk for interstitial lung disease, especially in dermatomyositis. They can get cardiac involvement, and they can have esophageal disease, which can lead to aspiration. This is an example of a patient with interstitial lung disease, also developed pneumomediastinum, so they can get inflammatory infiltrates, pneumothorax, or pneumomediastinum. There are certain antibodies that are associated with these disorders. The vast majority, but not all, have a positive ANA. Anti-synthetase antibodies are associated with the anti-synthetase syndrome. Anti-signal recognition particle, or SRP, is associated with a very severe myopathy, which is hard to control. Anti-MDA antibody is associated with interstitial lung disease. These patients can also have dermatomyositis. As you can see, the patients can have significant morbidity associated with these diseases, not just related to muscle disease, but with concomitant complications. And interstitial lung disease is the big player here. Antisynthetase syndrome is something that we should mention. It's a pentat associated with fever, Raynaud's, inflammatory arthritis, interstitial lung disease, and mechanics hands. They get these chapped fingers like this. And these are very characteristic features. When a patient says they're getting cracks in their fingers and they're feeling weak or they develop interstitial lung disease, think of the antisynthetase syndrome, Jo-1 antibody being the classic antibody associated with this syndrome. Treatment regimens in inflammatory myositis, corticosteroids are used in almost all cases. In most cases, a DMARD is offered, including methotrexate, azathioprine, mycophenolate, or tacrolimus, or other calcineurin inhibitor. Sometimes we use cyclophosphamide in bad cases that involve interstitial lung disease. Rituximab may be useful in certain subsets of patients. We use IVIG in patients who have severe muscle involvement, who have refractory disease. There may be some role for T-cell co-stimulatory inhibitors, such as abatacept, and there are numerous other active trials going on in inflammatory myositis. But suffice to say that most patients get high doses of steroids in combination with a DMARD at some point. So in summary, scleroderma, you need to recognize clinical patterns. The major morbidity and mortality associated with this disease is lung disease, taken in the form of interstitial lung disease and pulmonary arterial hypertension. There are many treatment options that are available now, and early recognition of this disease is important. Sjogren syndrome, we recognize clinical manifestations, sometimes marked by systemic disease, and these patients are at a higher risk for lymphoma. And then in inflammatory myopathy, we recognize that there are different clinical patterns. There are a variety of antibodies that can help you make this diagnosis. And again, the major morbidity associated with inflammatory myopathy is lung disease or interstitial lung disease. If you think that someone has an inflammatory myopathy and they're not responding to treatment, as I mentioned, consider the diagnosis of inclusion body myositis, which is a difficult diagnosis to treat. Board question number 1. Here's a 53-year-old female with a 20-year history of Raynaud's, develops fatigue and dyspnea over the preceding 6 months. They're on nifedipine, their blood pressure is controlled, notable for a prominent pulmonic heart sound, scattered telangiectasias in the hands and face. PFTs are done, which shows a diffusion capacity, which is 48% predicted, which is low. They have a normal oxygen saturation at rest, but have modest desaturation with activity. You do a cardiac echo, and it shows an estimated right ventricular pressure of 48 millimeters of mercury. What is the appropriate next test for this patient? A, CT angiogram of the chest, high-res CT of the chest, pulmonary artery catheterization, or exercise stress test. Great. So there's some spread on this case, and it's inching around a little bit, which I think is interesting. So we'll have something to talk about. So the correct answer to this question is we'll stop there, and I'll move on to the answer on the next question. Next slide. The answer is C. This patient needs a cardiac catheterization. The longstanding history of Raynaud's raises the question of a connective tissue disease. And the telangiectasias are seen in the CREST syndrome or limited scleroderma. Given the decline in diffusion and the echo findings, pulmonary hypertension remains the greatest concern, and this patient needs to get a right heart catheterization to confirm the diagnosis. A CAT scan is not a wrong answer. This patient could have concomitant interstitial lung disease, but the most likely clinical scenario in the context of someone with limited scleroderma with these clinical findings is that they've developed pulmonary hypertension. Let's go to board question number 2. A 51-year-old man with diffuse cutaneous scleroderma is admitted with new onset hypertension associated with anemia and thrombocytopenia. The blood pressure is elevated, skin thickening over the face, chest, hands, and legs. The lungs are clear, the heart is regular, and there is edema in the legs. Excuse me, go back one slide. Can we go back one slide? Thank you. The hemoglobin is 9.8. The platelets are low. The creatinine is 1.4. The urine shows 2+ protein, no casts, 2+ schistocytes on the blood smear. And so the patient is started on captopril, 6.25 milligrams every 8 hours. And then the captopril is escalated. 3 days later, the blood pressure is better, but the creatinine is now 2.1. The urine still shows some protein. Which of the following is the most appropriate next step to do for this patient? Discontinue the captopril and begin nifedipine, continue to increase the captopril, start plasmapheresis, do an angiography to assess for renal artery stenosis, and or order the RNA polymerase III antibody. Good. So we'll stop there and we'll move on. And the correct answer is B, as most people said. This patient has systemic sclerosis with diffuse skin disease. This patient is at significant risk for renal crisis, which is the case here. Despite the continued increase in creatinine, the ACE inhibitor should be continued. This is a mistake that is made. People start to panic because the creatinine continues to go up. The ACE inhibitor needs to be continued because the creatinine can lag, and the patient's dependent on the ACE inhibitor to control the vasoconstriction and phenomena that are associated with renin and angiotensin, which the ACE inhibitor actually treats. The RNA polymerase III confers increased risk for renal crisis and is a good diagnostic test to order, but the correct answer is B. These are my references, and that's the end of our discussion on this topic. Thank you.